for this orientation program, and it is a very nice get together. Up till now we were on only WhatsApp. Now we are seeing each and everyone's faces and knowing their introductions and where which college. It is a nice pleasure that Vidyapeeth have kept such a good program, orientation program of CBD, and new things we are learning. So I thank all of them, Vice Chancellor, Dean of this university, Dr. Mitra sir also. Thank you.
Take this opportunity to thank the NCH and also Bhartiya for inviting me to discuss and being part of the curriculum development and also now training and implementation. So now what we will be discussing, morning you had a basic idea about what is CBDC and what are all these things. But now what we will be discussing is about specific to community medicine subject. So what is your expectation? And I'm not going to give a lecture, so it's more of a discussion. So let's have a dialogue. So what is your expectation? The next 2 hours.
Sir, our expectation is we want to transform the education system. Like what we were having the traditional way of teaching, now we want to go with something where people, the students will get skillful, and that the teaching learning should be student learning.
Okay. So that is your expectation. What else? Anybody else? Any other expectations?
Also, sir, when we teach, so there is a marks like 50 or 100 students are there in the classroom. So how can we make it?
Then what else?
Sir, so many students in our faculty, so many students they are come from the rural parts. This is one of the biggest problems they have to face, okay? Particularly during communications. If we are talking in the village, okay, so many times they do not talking. Okay, they cannot guide what we are talking about. Okay, so how can this face and how can we mold this thing?
Sir, already we know that community medicine itself is a very vast subject, and still we are adding a research methodology and biostatistics, unlike again a very vast subject into it. How it is being.
We also reduce the time. Unfortunately, that we will discuss about all these things here. Yes. Okay, I agree with all of you on whatever you have, your expectations. We will try to solve each one of them. And the CBDC curriculum has incorporated whatever your expectations are there. Including your English, what you're talking about. I think you have a first year when they come, they have some foundation course and electives are there where they can take up English also, which can be done. So let's, with that in mind, let's discuss this with a very open mind. What we want to talk about is how, what we have been doing. There is slight changes, not much changes. It's the same, the content is the same, but slight modifications in the content, little bit changes here and there. And the major thing is more competencies are listed, and after the competencies, XLOs are listed. And then what we were doing for 2 years, now we are doing it 2 separate years. That's the difference what we have. I would like to tell you all, or maybe it would be in, because community medicine is the only subject which is not released. Other subjects, at least you have the second year, you have some document. Community medicine, we don't have the document as of now, it's not released. So now, whatever major ones, I'll just show you, because others are content. It's going to be the similar one. Because, see, community medicine, why it is not released is because as of now, they only release in the second year. Second year, most of the subjects, OBG and surgery, all are there, so they are only released up to the second year. But community medicine is in the third and final year. Okay, so it cannot be released immediately. So that is, and the training cannot be done only for community medicine separately. So they have combined. So very shortly they will release in community medicine subject also. Okay. So what is it? We will go into the subject with that expectation. So it is for third and fourth professional course. So which is applicable from 2022 batch onwards. So this whatever we are doing is applicable. So you have a subject code. This will not work. So you have a subject code which is like you can see here Home UGCM1 and Home UGCM RF static. This is the code what is given. Subject code is going to be like this, and even in the Gazette the subject is like that. So everything is codified. So now, what is our learning objective for the next 2 hours? Is we will be discussing, we will be recall what we have learned about CBDC, just how it is done, but with specific to community events. There you heard what is CBDC in general. So we will look at what specific to community events. Okay. Then we'll outline a template of macro and micro planning. Macro planning is already done. Micro planning, which you will be doing later, which Dr. Munir spoke about the lesson plan, like why it is important. And then we will talk about the teaching learning methods, which has already been discussed, but we will see how little more recap of what was done. And we will illustrate what is the, how do we do this interdepartmental integration. Okay, that is also there. And then we will look at the what is formative and summative assessment and what can be done for community medicine. And then we will look at the assessment blueprint. So now, what is an assessment blueprint is we already have how the assessment has to be done. There is a question paper blueprint as well. So how it has been, what subject, what topic, how many marks, which question number, what marks, everything is listed out very clearly. And we have a layout. I'll show you the layout of the blueprint. And we will discuss something about the practice, the viva, and the scoring and clinical assessment. So this is what is our learning objective for the next 2 hours. I'll try to, no, I'll not take 2 hours, I'll try to squeeze it. I know it's not easy to say. But when we go as a discussion, there have been that we have gone up to 6 o'clock also. So that's how it was there. So now let's look at the first objective is recall overview of CBDC for the subject. So what we'll say, how does this CBDC subject came into and how the flow of syllabus system. So if you remember, Dr. Munir spoke about national goals and course objectives and all. So this is the community medicine syllabus. So it is derived, the flow is derived from the national goals. So what is it necessary for the national goals we have? And we will look at each of those goals. There are few goals which are common for the entire course. Okay, what are national goals? From the national goals derived as course goals or the program outcomes. That is for common for the entire course, the BHMS course. From the program outcomes, we have the course outcomes. Course outcomes is derived for specific for community medicine. That is at the end of the community medicine course, that is 1 and 2. That is the third year and final year, we have certain course outcomes. So one is at the end of community medicine course, that is after 2 years, what the student should be able to perform. That the competencies, that is derived, that is course outcomes. And then from these course outcomes, we have derived something called as domain competencies. So you know already, sir has explained about domain competencies. So there are 6 domain competencies. And from those domain competencies, each of the SLOs are derived. Okay, that is a content prioritization. So content prioritization are done based on the must know, desire to know, and nice to know. And I'll explain shortly how this has come, how the content prioritization has come. Once we have done the content prioritization, we have done the blueprinting for the outcome and the assessment, and we have the activities, what are the teaching learning activities has to be done, and instructions and how the assessment has to be done. So this is what is the flow of the syllabus. So from the course, the national goals, program outcomes, course objectives or course goals, and then we have derived the domain competencies. From domain competencies, we have taken up the content prioritization, and then we have the blueprint. So this is how the syllabus flow is there. Okay? Any questions? So now we look at one by one, what are these? So national goals. So national goals at the end of the undergraduate program, homeopathy graduates should be able to recognize the strength of homeopathy and its applicability, the limitations in healthcare of the society and individual. This is the goal, national goal. Okay. Then the second one is they should be able to integrate the homeopathy along with conventional line of treatment for effective delivery of health. Then recognize the purpose of national health policy, the health, that is the health for all, as national goal and health right of the citizen, and undergo training to achieve the realization of this social responsibility. They should have a scientific temper, that is what it is telling, where they will be able to acquire the educational experience for proficiency in the profession, which profession, the homeopathic profession, and then they will be able to promote healthy living, that is what through homeopathy, that's the objective. And they should become an exemplary citizen by observing, they should follow all medical ethics. Okay, we should fulfill, or the candidate should fulfill all the social and professional obligations which will help to respond to the national aspirations. Next one is to achieve competencies in the practice of homeopathy with holistic approach, okay, which encompasses the promotive, curative and preventive, all these what we talked about, the health and the disease. Okay. And the most important is we should establish, or the candidate should be able to establish homeopathy as an evidence-based system of medicine and practice. Okay, this is the national goal. What we expect out of the candidate. Now we will come to the program outcomes, that is for the BHMS. These are the national goals. The program outcomes at the end of BHMS course, the student should develop the competencies which are essential for primary health care. Okay, basically in clinical diagnosis and treatment of disease through a judicious application of homeopathic principles. Okay. The next objective or the outcome is he should be able to recognize the scope and limitations of homeopathy and apply the homeopathic principles for curative, prophylactic, follow principles of curative, okay, and then rehabilitative primary health care and secondary health care for the benefit of individual and community. Okay, discern the relevance of other systems of medicine and for rational use of cross-reference. So we should know what is the other system of medicine, we should know our limitation, and when do we have to do cross-reference. They may do reference to us and we have to do that reference, cross-reference. That is the other outcome. So we expect that the BHMS candidate should develop critical, which was already discussed, critical thinking and research aptitude as required evidence-based homeopathic practitioner. Okay? Demonstrate, you should be able to demonstrate the aptitude for lifelong learning. Dr. Munir explained what is lifelong learning. And he should be able to be competent enough to practice homeopathy as per medical ethics and professionalism. And develop a necessary communication skill, and because they have to work in a team, they have to work with the doctors, individual patients and in the community. Okay, so they have to develop that, and it should be in the larger healthcare setting, and it should contribute towards the larger goals of national policy, school health and okay. And finally, the most important what I feel is for community medicine, this holds a lot. Identify and respect the socio-demographic, pathological, cultural, environmental, and economic factor that affect health, because if we don't identify that, they will not be able to treat the disease. They should be able to identify that and manage with homeopathy. This is what is the program outcome of BHMS. Okay, so these two are common for all the subjects. Now let's move on to the course outcomes. Now, course outcomes, so there are 10 objectives over here, what we are looking at here. First one is the community health. So in the community health, he or she should be able to recognize the community health problems, apply the clinical skills, and manage the problems using homeopathic principles. That is the community health, the first one. The next one is determinants. So here determinants, the candidate should be able to identify the determinants of health and disease, okay, and use this knowledge for prevention and control of the disease and promote good health. Next one is about the disease. So he should be able to identify the disease, prioritize the disease, because there might be situations that we may have to prioritize what to do. So he should be able to prioritize the disease, manage it, report the disease of public health importance to the authority, whoever is the authority they are supposed to report. They should be able to report at the appropriate. Next one is about the epidemic or outbreak investigations. Okay, So the candidate should be able to outline the process, or he should know how to do an outbreak investigation or how to manage an epidemic with homeopathy. Okay, and then screening of disease. So here the student should be able to participate in the screening of diseases both at individual and community level. Next one is the community participation. It's most important. He or she should know how to participate with the community, how he involves the community in all the disease prevention activity or duration or health education and all. Because without community participation, we cannot do anything in the community. If community is not supporting, we cannot do anything. Because what we have to do is all use the community. Okay? So he should have that skill. Then the behavior. So here, because any disease, you take it either communicable or non-communicable disease, behavior is most important. So the candidate should be able to identify the community behaviors. Why we are talking about not individual behaviors, but when they sit in the clinic, they should be able to identify the individual behavior, as well as able to analyze the community as a whole. Because behavior as an individual will be different, when they come as a community as a whole, it will differ. So the student should be able to identify the community behavior and what are the diseases which are associated with that behavior, and be able to provide interventions. Because interventions are, you may say they are same, but it varies from community to community, because community as a whole is different. They behave differently, their culture is different, the way they see problems are different. So this particular student should be able to identify that and plan an intervention project. Okay, next one is all epidemiological studies. So whatever we are doing in epidemiology, he or she should be be able to factor in the epidemiological principles, especially when conducting any kind of research, in terms of how do they collect the data, how do they collate the data, how to analyze the data, and then come out with a report of public health problems or community health problems. Next is about the health programs. The candidate should be able to plan and participate in implementing a national health program. Now, we may not be doing any planning at present immediately, but later in future they will be able to plan. They may be involved in the plan of any national health programs, or while implementing they will be involved in planning of that. So he should be able to plan and participate in implementing national health programs. The next one is about the research design. They may not be able to do a complete research, but we have NCH has got research for when the second year and third year research they are giving grants. So at least they should be able to identify what research design they have to select for, at least how to do and what to do. They should know what are their limitations or to conduct the research. So these are the 10 course outcomes what we are expecting after they complete. These are all like competencies. They should be able to do all these things after the 2 years of community medicine education. Now, do you think anything which we have missed out? Anything which needs to be added?
So can we see all the points at one go?
At wall, at one it cannot be seen. First point you want to say. The first one is the community health. Then the determinants. Okay. First one is community health. That is covered in the community health. Everything is covered. So these are all the outcomes. See, those are all coming as individuals. So outcomes is when the screening of the disease and manage that all will come into that. Occupation health will come into that. Okay. So community health, then determinants all the problems. Okay. Then screen disease, screening, epidemics. Okay. Then community participation. Then we have the behavior, epidemiological studies, health programs, research. That all will come under community health. So this is the overall picture, and then we are breaking down it further. So this is an outcome. So again we have the course outcome separately. So there you have whatever you are talking about NCH and all those things. Anything else in the broader you have been missed out? Yes? Huh?
Preventive aspect नहीं
Sir, preventive ही है. When we are talking about community health, we are talking preventive, curative, promotive, everything we are talking about. The focus is more on prevention. Huh? That means now they are all part of the research and epidemiology. So these are the overall. From that we are deriving something.
Homeopathic aspect should come over here, like
Everything is integrated with homeopathic aspect. It's not as a separate. That's why we have something called as integration. So every topic you have to integrate wherever necessary. We have given something very few, but you can integrate wherever it is possible. Bring in organ, bring in medica, bring in therapeutics, repertory you can integrate. As an example, few are integration are done. Rest you can add. The beauty of this particular thing is it's giving you some guidelines, idea what needs to be done, and you have the freedom to go ahead, customize. Okay, you plan, you implement how it is necessary, but structuring is already done. You have complete freedom to modify within that structure. Okay, how to plan and how to implement it is there.
because everyone is getting different audience. The communities are different, the localities are
Yes, that's why we can't give.
For our requirement and needs you can modify.
Yes, that is why we cannot give everything because your problems, health problems are different than others. So you can manage that accordingly. The list of diseases, everything are given. Everything is clear, but it depends on how you take it forward. So depending on your needs, you can do. So now, how is the structure, the organization of the syllabus? So if you see, this is what is the table of contents out there. So you have the list of tables, list of figures and all. I'll show you in a larger way. This is for the third year. So similarly, it is for the fourth year also. It's in the same document. First it is in the third year, then in the fourth year as of now. But NCH may change it, like they bring third year separately and final year separately, but they are all the same. Okay, so we have the program outcomes which you already saw. Then we have the course outcomes, the competencies for community medicine practice. Then we look at teaching hours, the content, the teaching learning methods, how the assessment has to be done. These are all general. Okay, then we go specific to third year. What are the topics? So we have listed all the topics. Then the table, the competency table, what Dr. Muni was explaining, that big table. We will go into details about that. And then practical training. So we have tried to give a lot of practical aspects into this. You may tell that there is so much, but we don't have time. But what I always say that we are all Indians, we know how to do budgeting. Within that budget, we know how to manage that. We have been doing at our house. So we should be able to do with that timings also. Okay, so there are a lot of field visits and activities because community, they have to learn what is there in the community. So field visits are there. So you may have to manage that. So assessment and then the list of this. So now what is it different in what we were doing and what the CBDC syllabus is? Can you tell what are something different which you have heard from morning? Knowledge to performance, yes, because it's competency based. So what the skill that person should be able to have, that we have changed. Okay, then what else? Implementation. Integrated skills. Skills, transformation. The most active learning, the most important, it is student-centered. Learner-centered. Okay? It is all revolving around the student, the learning. Okay, what the student should be able to perform, what are the skills, what are the competencies he is going to gain, and how is he going to gain. And sir also mentioned about each one of us learn differently and each one of us learn at different times. So it is at what time he is going, that's its own place he can learn. So that is learner-centric. And the syllabus is structured. Entire thing is structured, like we have the course objectives and each objective, course objectives, then we have the SLOs written in here, then what are the teaching learning methods and assessment. So they are in structured. Everything is there. Yeah, so they are in structured. Okay, then we have what is the expected outcome of the student. So at the end of the chapter, if you see, we said at the end of the chapter you will be able to recall the CBDC. So something like that for every chapter, the outcome is expected is clearly defined. What he is supposed to do at the end of the course, at the end of each class. Okay, that is clearly defined. And the outcomes, competencies and outcomes are clearly mentioned. The contents are organized based on the domains, okay, and Gilbert's hierarchy. So the competencies, how they are, like you have whether it is a cognitive domain, psychomotor domain, or affective domain. In each of these domains, they are in 3 levels. Gilbert's level, level 1, 2, and 3. Okay, so that is how their hierarchy they are arranged. Then you have the freedom. You can innovate, you can do what you want, and depending on your cohort, you can modify. It's not necessary that you follow one method for every batch, because each batch is going to be different. You can innovate how you want to think. Today you might have done a class for 1 hour. Tomorrow, next batch, you may do it for half an hour. Maybe later you may have to do it for 2 hours, because it depends on the cohort. It's very dynamic. Okay, so you can modify things how you want. And then you can use various teaching learning methods and media. We have listed few methods and media as an example. Now you can choose what method according to the domains. Like we will see based, because the methods can be based on the domains, based on the size and all those. Okay. And then the blueprinting has been done for the learning and assessment, and it is all practice oriented. If you see all the learnings, the SLOs are all practice oriented learning. What they will be able to do. For example, the student should be able to define something, should be able to categorize or classify something. So like that, that is very clearly mentioned. It's all practice oriented. And finally, it is not that it is our responsibility alone, it is also the responsibility of the student. Everybody is accountable. The student is accountable, the teacher is accountable, the institution is accountable. All 3 are accountable, all stakeholders are accountable. Okay, so this is what is something different, or what are the salient features what we have in our, or what we have in our CBDC curriculum. Is this something which we had before? No, it's all different. So now, actually we had planned a lot of activities, but because of time we are not doing activities. So now what you could do is, once you go back, because most of you all might be coming from a single university or 2 universities. So what? Single university, MUHS. So what you could do is, now the entire curriculum what we have done is like 12 for 1 year, 3rd year and final year. But we will not get time. And why we have not done this is because each state is different. You have different timings, your university timings are different. So what you could do is, you can rework on the topics, make it as modules, or month 1 what all you have to do, month 2 what you have to do, month 3. Because you have your different calendar of events, so according to that you can plan. Okay, so you can do that as 9 months. Why we have taken 9 months is, when your exams will go, holidays will go, all that, so we will approximate only 9 months, so within that 9 months. Now we will see how the syllabus is structured, how the delivery and different modules, and what are the competency tables we will look at. So these are the teaching hours. This is where we are budgeted, and we are in community medicine at a disadvantage is because we have, as sir was telling, we have large content. But unfortunately we have to reduce the time. That is because we did not reduce X. It was already gazetted. So within that time frame we have to work. So we will all request to increase time. We will ask somebody to donate time from other subjects. But it is difficult because they also have asked. But we know how we can manage. So for 3rd year we have 160 hours, where 100 hours for 3 years, 60 for 12 years. No, because we have equally divided. We have not given this timing. This timing was already given in gazette. So we had to work around the timing. Okay, so we will see if it can be done, but what we request, if it has to go, it will take some time for them to go with an amendment, it has to go to the parliament and come as a gazette, it will take at least 4 years. Yes, that's how it is already done. We have already done and divided. 4th year, research methodology. See, research methodology, you might be thinking as a separate subject. No, we have included that in the final year as one of the chapters. For fourth year, they have given us only theory as 71 hours. I don't know why it's 71 hours. I think others have taken most of the hours. Because of the calculation left of 1 hour they have given us. So, and 75 hours practice. Okay. So this is what we have our timings, our number of hours. So how the structured delivery is. So what we have done is third professional term 1 and term 2, fourth professional term 1 and term 2. So if you see this table, you will see the serial number and you have the themes. Now why this? Every subject, if you see all the first year, second year, third year, all subjects are done as different themes. But themes are for exam point of view. But for community medicine, whether the theme is there or not, it doesn't matter, because for us each of the topics are different. Unlike in material medical or organ, they have group of aphorisms or group of drugs or something like that, because they cannot specify drug 1, drug 2, drug 3, so it is not made as theme. But for us, it is some kind of an appendage. We don't need that, but because the structure is there, it is there. Okay, so now this is how it is, the teaching number of hours, and then your marks are given. These marks are given as for the summative assessment, not for the formative assessment, the university exam marks. How much marks is allotted for each of the subjects. Now you see some subjects, some topics, we are having 0 marks. Like for example, this fundamental introduction, history and all. We are not asking them an exam. Why? Because it is not a competence. It is just a cognitive. So we are not asking exam. If you want, if you think a student will not read this, you can ask that in formative assessment. You can assess that whether their knowledge in formative assessment. But we will not assess in the final university exam. Okay? So you can have a look at this for term 1. So fundamentally concept of health and disease. See, then if you see everywhere homeopathy is involved, it is not separate. So now if you are talking about nutrition of the community, please include homeopathy inside that. It's not as a separate one. So you have to integrate by default.
So we can discuss the aphorisms which are there for the
Your freedom. You do whichever aphorism you want. You want to discuss aphorism, you want to discuss drugs, material medical, or you want to discuss the repertorization, it is left to you. Your freedom, whatever you do. So you can innovate, you can do creative, and then you can share among yourself, this is what I do. Okay? So this is for term 1. Now let me go to the term 2. Third professional. So this is how it is structured. So we have reproductive, maternal and child. You might have thought about LCH. So we have taken all the latest, whatever is being used in the public health and community medicine. All the latest ones are taken up. And we have Vidyapeeth, which was there already. Then we have included health of specially abled population. Like it would be autistic children or something. At least they should know medicine. So suppose you go to an disabled orphanage or something like that, they should know how to do at the community. What needs to manage. Okay? So how we are doing that, so that is there. Then another thing is we have divided the communicable and non-communicable disease into 2 different tiers. Because they both together is vast. So it is very difficult for students to remember all the disease. Luckily it is 2 different exams. At the end of third year 1 exam, at the end of final year 1 exam. So we were able to partition it and separate it. Okay. And there is no separate national health programs. Or based on that disease, you include the national health program and then top. All applied aspects together. Okay? So it will not be discussed separately. And then occupation, this is for the third year. So we have 100 teaching hours, 57 here and 43. Okay, so term 1 and term 2. Now these are 12. So now you bring it to 9 months. It can be managed. Totally we have 100 hours for third year. Now fourth professional. So these are the topics.
this will be for theoretical as well as practical.
Yes. Practical, I'll come to that. Everything is like that. The practicals are also aligned to this theory. Huh? Sorry? Not even here.
Theoretical.
nutrition. So nutrition related practicals will be done in Bhartiya. And I'll show you that also. Okay, so now we have in this we have the hospital management is added because that's also needed. Because that's all, somebody has to go and start a clinic, or if they want to work in a hospital, how they have to manage. So that basic concepts, not that they are learning completely, basic concepts. Then we have the health economics, health financing, all those things are as an introduction there. So we have the foundation of research methodology. So though the subject says research methodology and statistics, we are only talking about foundations of research methodology. More detail they will learn in their masters. Okay. So now with a lot of technology is there. So how health management, information system, digital health, all basics, health informatics, telemedicine. Then you have now everything is now all digital. So those things they should learn. So those topics are yes, it's there.
From the practical point of view, many places are talking about public health, and they are expecting our students to go to BHMS and rural hospitals. But usually what is happening in Maharashtra that there is no fear as such, our students can be responsible, for a certain duration, one day it is okay. But if you are sending them for posting also in learning, it is not possible.
Yeah. I come to that. This problem is there everywhere. So what we have done, this is already put in we have told, for example, they should be posted in PHC for 7 days. Okay, why 7 days? Let me also tell you. Now, because if you take them to 1 day PHC visit, generally as of now we are taking them only 1 day. Now what happens is they are just seeing what is happening in that 1 day. Okay. Because in BHCs in India, Monday there is a different activity, Tuesday different activity, Wednesday. So now what we are telling 7 days they should be going. Now the 7 days doesn't mean it should be continuously. Within that 1 year, you take them 1 month, Monday 1 day, then Tuesday next month. Depending on your time, you can take it. But ensure that they go to every day of the week they are going. It is already written what there are a lot of activities. You can show this is what is gazetted in the NCH curriculum.
So, if there is some labor later, so usually they are approaching the authority are saying there is no GM like this, so we cannot depute your student. So if it is there in the gadget, please let me know.
So now this will all be gazetted. So now this is coming as a national NCH curriculum. So this is real, it is written there. And in the first page the gazette will be there. All the reference will be there. So now they have to take it. If not, we will request, I think from the university,
But the state government is there and local government is there, so
that they
should be there.
happen.
Yeah.
We will see that practical implications. We have 1 year time. We will see how it can be done. But every zone they have brought up this point, and I've already informed the NCH in writing. You also, all of you will write what this is a problem. We will get it done, because that is the key. Most important for our students to see and learn. See, theoretically you may tell, but once they see, they go there and feel and observe, they will learn much better. And our focus, you can write to NCH, please do write to them that this is what is the problem we are facing, come with a solution. You can write. But anyhow, I'll also make a point to them, because there are 2 points which everybody has brought. In one is this, the other one is a timeline. So we will individually we will write, and we will write as a group also. Basic health economics and health finance. So what, like for example, what is GDP and GNN and all those things, they should know the basics. Because we are talking about finance, they should manage basic idea. So nothing much.
I think when we are going in public health, you have to.
So all these things are there. They need to manage. See, if you see the topics what we have put as a in public health. So everywhere you will sometimes you have put community medicine back public health. They are all the same. The only difference is slightly in management aspect. There is nothing much difference in this. So our students should not be devoid of anything. So they should get the maximum. They should learn. So all according to that we have to prepare. If anything is we have missed out, please bring it on notice, we will add. Because it was done in a hurry, because we didn't get much time, but within that, whatever time was allotted, we tried to finish it. Here, if you see our objective, the national goals, they said we should know where we should, what are our limitations. So if a patient comes to you, they say, I have taken this drug. You should know what is the drug. So now, even in CBDC, they are learning the pharmacology. So that is why, what are the essential medicines in for community medicine? They should have an idea. If they go to BHC also, they will tell these are the things they are there. When it comes to an epidemic, they will, because, for example, during COVID, we were pushed into do anything. Without knowing what we are doing, people have done. But here what we are doing, they at least have an idea of what it is. They are not going to practice. They will just an idea, these are the essential drugs which they have been using.
So last slide, you showed that recent advances.
Yeah. Now why recent advances is, if you see our curriculum changes once in 10 years or once in 15 years when it was changed. But what we miss out is what all the changes are happening new. For example, COVID or Nipah or let's say Zika. Now we know we are included. But what if something new comes, we cannot teach that to our students. Okay, so what we have done, whatever comes in that recent advances in 1 year or in 6 months, they can have a discussion, you can teach them. But if you see, we are not asking, assessing, it is only for knowledge purpose.
Nice to know.
Yes, it's nice to know. Okay, that is what it is. Here, that is why, because at least they should know what are the recent advances, what are the new things. Not only what we will do, we are so much bothered about the curriculum. We only talk about the curriculum, we don't talk about what is new. So by this, at least students will get to know what are the latest things which is happening. Okay. And we are not given much, only 1 hour. That can go as a journal club or you can do self-directed learning, however you want. But 1 hour we have. Here, any topics which we have missed out? Not topics, the major topics. Yes. You have demography and family planning, you have practicals also. You have to do surveillance, demographic surveillance. Each student will be given 5 houses, family adoption, and they have to follow that. And then you have to do a demographic surveillance of the region, and you follow that family and see how the changes are happening, whether the demographic is changing. Okay, that is because if you know that, you will be able to design interventions in your community. Okay, so that's why this is a continuous process. Clear? Shall I move further? Huh? Now it is already added. You were doing it on your wish, but now it is compulsory for everybody. Yes. One that today now it's a new concept where they are doing everything in one digital level. So that is what is happening. All details are given in one. We go to government of India website. Now they are bringing one web concept where all things are brought into one. Like one window, one roof, everything they should get. Then management will come in. Now, for example, they don't have to go for maternal health separately, for tuberculosis separately, everything is coming together. It's all at one place they are. That's how we are.
Sir, it's a request that we are doing some hours, fixed hours for lecture study and some lectures for the practical hours. So among them, we should get some separate hours for the family visits. At least one.
Sir, I'll tell you, we have got 60 hours of practicals. That is what we have. Now, the 60 hours is not sufficient. So what we do is, because we don't have much of practical in the sense the lab, except for the spotters. So spotters you can finish in 3-4 days. Whatever spotters are there. There are some 5 or 6 experiments which you can finish again in few hours. Then, if you see, I was calculating visits are also there. Full day. Family planning.
because the family should be available on that particular day
Yes.
and for that
So
particular hour.
that is why practically what we do is, even we do family adoption, and most of the time this family visits are early morning or late evening. It is not during this work because the family have gone for work, nobody will be there. So that's how you have to adjust. Now you have to manage the timings. Somewhere we have to adjust with our theory, somewhere we have to adjust with our practicals, with other subjects. And if you see, most of the time the clinicals, not that they are doing clinicals throughout the week. Sometimes you have, sometimes you don't have. Try to maximum utilize that. I understand the time is less. We cannot budget everything.
Precisely how many hours should be.
That is come. That is done. That is come. I'll show you. We'll come there.
Because at the
Environmental health नहीं है।
हाँ?
Environmental health।
वो कैसे बोल सकते हैं environmental health? सबसे बड़ा है। Okay, now let's look at how it is structured, the competency table. So this is one example of one one topic, one unit. I'll explain this competency table. Now if you see what Dr. Munir was explaining, competency table, then domain competency pillars and all, so we will see each one of them. So now this is the unit number or the chapter number. At every table what we have. So we have our community medicine syllabus is around 360 pages. Okay, so in that all the units are done according to this table. So this number will be the unit number, or we call it as a chapter number. Then this is the name of the chapter or unit. Okay. Then this is the competency number. Okay. Now what is this competency number? If you see here, you have Home UGCM1 T2.1. So that is the competency number which is there. So here if you see the first one, it's a competency number. Now how to read this and how to interpret this? This has to be read as Homoeopathy UG. Okay. Then CM1 is community medicine third BHMS. Okay. Then if you see there is T component. T is theory component. Okay. For practical we have B. Okay. Then you have the number. Unit 2.1. So if you see the number, unit is 2. Chapter 2. Point 1 is that after decimal it is the SLO number. You see each of the SLOs are different. So these are all the SLOs. Okay. For all of them it is like 2.1, 2.2, 2.3. So those are SLO number. Point after decimal it is a SLO number. Clear? This is how the unit, the competency numbers are, they are structured. Numbering is being done. Clear? Now we look at what is the domain competency. So domain competency is KS. Dr. Munir explained this, so I will not go into detail. So KS is knowledge and scholarship, something which is related to knowledge. PC is related to patient care. HO is for homeopathic orientation. The other one is communication skill. Then PBL is practice-based learning. PRF is professional. Wherever this competency is there, they are listed. Sometimes there may be more than one competency, sometimes there may be interchange. So if there are anything, then you can add to it.
So why scholarship?
Scholarship is knowledge and what they are supposed to learn. That is what we are talking about. It's on cognitive domain. Huh? Scholarship is knowledge. Okay. Next we will look at the Miller's pyramid. So if you see Miller's pyramid, as sir explained, 4 levels. So nose how shows and nose is for cognitive. Again this is nose how is cognitive and psychomotor. This is completely psychomotor. This is more psychomotor and affective. That's what they are doing. Content, the list of contents are specified. So what is that? You see here, health, disease causation, concept of the content. Okay. Next is the specific learning objectives. So these are statements. Okay, what the student should be able to do after that particular class. That is a competency. At the end of the session, you should be able to do that. So that is the competency. Now all these competencies, they start with the active verb. You must have seen Dr. Munir explaining what it is. So it's all starting tonight. Then we have the next one is the Bloom's taxonomy, which domain it belongs to. Okay. And then the Miller's pyramid. Okay. The Gilbert's hierarchy. So C stands for cognitive, P for psychomotor, A for affective. Then Roman number 1, 2 and 3 is the level, Gilbert's level. So all these things are explained in below one table. The first table, all these explanations are given. Okay. And even in the third year document, the second year the introduction document, the table is explained using this. So this is the prioritization. Must know, desire to know, and nice to know. Okay. Must know is the student should know this. Without this, he cannot practice. Desire to know that it is good. Nice to know is good to know, but it is not necessary that. So we don't do any assessment for nice to know. Next is the teaching learning methods. So here, in the document we have given only one or two, like it will be a lecture or small group discussion. But you can see what is the SLO, which domain it belongs to, and select appropriate teaching learning methods. Because we have around 14-15 methods. We cannot list out all that methods. If we list already it is 365 pages. Now if we list out all that method in each of the SLO, it will go up to 1000 pages. So we have not listed, but in one place we have listed all the teaching learning methods which you can select from. Then we have the formative and summative assessment. Formative, what all can go. Now if you see summative assessment, in each of the SLO, it is given LAQ, FAQ, or SAQs, all these things are mentioned. Now if LAQ is not mentioned, that means you cannot ask for 10. Long answer, modified essay. Short answer, this can go for 5 marks, this can go for 5 or 1 mark. That's how it is.
And what about modified essay?
That is in long answer. You can take anywhere, you can use modified essay. So not assessed wherever NA is written, that we are not assessing, especially for the nice to know topics. So don't ask any questions from that. Now next is integration. As I told you, there is both horizontal and vertical integration, and you can decide where you want to. We have specified few. For example, here for disease causation, we are talking about you have to integrate with organon. So this you can either, if you know, you can do it, or you can call the organon teacher and then we can do it. Similarly, you will be going into the other subjects, maybe with community, in OBG or medicine or something.
That will become vertical. If you are going to the upper classes.
No. Vertical is from like second year, third year. Horizontal is the same class, different. But for us, it will be both. It will be both. So we.
Spiral.
It can be anyway. That's what I'm telling. It will be both the ways for us. It will not be in one. See why it is vertical or horizontal? Because if you see the American curriculum and all, they have a horizontal. XR explained, right? The competencies. So every anatomy, physiology, everything will be done, and then they go to the next system. But for us, we don't do like. So that integration is done. Now we come to the practice.
How only we have to start doing integrating the practice of medicine technique?
But we don't have a subject. No. In practice, in medicine it is there. Community medicine we don't have.
We have to do it.
You may have to go and do it for. You have to go and do it for pathology, microbiology, OBG.
So this is started of second year.
No, from first year it is started.
For this community medicine.
Yeah. So from community medicine it is from second year. So you have to go and do it. Yeah, that is how it is. Yes. So that is why you can do integrated teaching or team teaching. All of you can do together. Or you finish one and then they do it. Or if you know organon, you can integrate it and do it. So it's up to you. So now these are the practical Competency is what we implement. No, community medicine we don't have in second, third and final year. So, what happens in practice of medicine or in gynecology, wherever community medicine part will come, they will invite you to do it. Okay? So now these are all the competencies for practical. So you should be able to screen the disease, recognize, notify the disease, perform the spot mapping, perform nutrition assessment, plan a balanced diet, perform antenatal care, counseling, advice for family planning, conduct health camps, perform occupation. You see, all are practice-based. Everything, whatever they are supposed to do is practice-based. So this is what is the practical. The competency is what they should acquire. Okay. Now how they are going to acquire, we have to put that in the competencies. Okay. Now, spot mapping that, for example, you go and suppose you identify where the vitamins are there, where there are, where you identify and map that. That is called spot mapping. You know John's slow story? Yeah, cholera. That is what. Now what? From spot mapping only, from that only we have the GPS, the GIS. What you are using? Yes. So you can use however you. Yes. You can do. No, they should be able to screen for various diseases for public health importance. They should know one is knowledge, and wherever they can go and do, they can do. So we have specified, for example, diabetes. They should be able to perform the test. Hypertension screening, they should be able to do it. Wherever possible, they should be able to.
Now the Ayush's insisting to go with the neurotoxins.
Everything they are doing. So taking all that into consideration only, we have put it BP program. Okay. So now in practicals, there are 4 components in practicals. Okay, or in practical training what we have. One is the laboratory work. In the lab, you do some experiments, basic experiments what we are good at. Okay. Then we have field visits. Then we have some clinical and hospital postings, because you should do the case taking for clinical social case taking has to be done. Okay. Then the community based activities. So these are the 4.
Now we are doing communicable diseases, these infectious diseases in Britain. Now we are pointing out clinical,
Social.
So now it is community based.
Community based. So it can be done either in the hospital or it can be done in the community. It's basically how we are doing the social, how the demographics are changing, all that we are doing. So this is why we are doing. Why all the community-based activities are done, because we help make homeopathy more popular, improve visibility, acceptance of system, the field work, they can conduct research. It is going to provide students an opportunity that what they are going to see actually in future. So that's going to give them the knowledge and the experience which will come. And it is going to build a good relationship between you and the community. Okay, and the college can design intervention program. Okay, and if our students are going to the community, who knows, the other students who are thinking they may get inspired by this and they may join homeopathy. So like that, there are a lot of advantages. Why? Our department alone can give to the community. Okay. So these are all some of the field visits for 3rd year and final year. Now, please don't tell that one visit will go the entire day. Yes, it will go, but we have to somehow manage. So these, like if you see, they are all chapter wise. How you saw the topics, the visits are also based on those chapters. Huh? Visits are there for both the years. They are according to the topic. So now suppose you have finished the healthcare delivery system, they learn the theory and they go for the practical according to the topic. So they are structured according to topic only. Now if you see nutrition is the third one. So their nutrition is again after the, that's how it works. Mandatory. So see, to be honest, initially we had two visits. Now why? Now I've changed it to one visit. Now initially when we did the first training we had put two visits. The reason we had put two visits to sub-centers is because sub-centers are different. In rural they are different, in urban they are different. If you show one, they will not know the other one. But as you are told, there is a problem of permission and visit. So now you do one or two visits, but at least one you should. So all those things. That's how it is. And because the PHCs also in rural area PHCs are different, in urban area PHCs are different. So you have to expose them to maximum. So wherever possible, expose them.
So here also sir, we are losing on some hours because other classes are also not there because one day or half day at least we go before this.
Half a day will go, I know that, but sometimes you have the clinical hours. You can take from that particular, even now we are doing the same thing. If you see the last time also our visits, the number of hours and our number of hours what was given to us was less. But we have been managing and now also we will be managing. See, community medicine is budget. We always manage. We have to work in resource poor settings, so we know how to manage in resource poor settings. Okay. Yeah. Okay. So these are all other visits like for environmental. So we have to take what we are supposed to do. This all you will get. You will get see occupational visit, industrial visit. You have to do what you have to observe when they go to industrial visit. So like that I clearly mentioned. So this is community-based activities. So you we have to finish already. It is 3:45. It will all come in the NCS portal. This is just for our discussion. This is put in the slide. Otherwise, you will get in the PDF. Okay, now we have problem of who should do what. So you said permission we have to take, and also here what we have done is what is the responsibility of the college, what is the responsibility of the teacher, and what is the responsibility of the students is clear now. Okay, so that it is responsibility of the college to adopt the village. Both they take a responsibility here. Anyhow. So people have come and asked, told me, sir, you are telling our college don't give vehicle. What should I do? Logistics arrangement is left to the college now. So these are practical problems, but you have to manage. So now here, this is an example. It is just a minimum. It is just an indication what you need as you can plan accordingly. So laboratory postings, we thought 5 hours we can finish the entire, all the spotters and all those things, nothing much to be done, right? So you can finish that, then you can use 2 hours per week for clinical postings, hospital postings. You can do it in a month or you can spread that over a period of time. Okay, not necessarily 2 hours per week every week. So around 8 hours if they get in a year, I think that is sufficient because they are case taking. Once if you explain them how the case taking is, then they will do 2 or 3 cases and then they will be done. Next one is you should post them in peripheral OPD because community based, they should know rural problems and all. So at least 1 day in a month on a rotation, please post them wherever you have. Not much, 1 day in a month. Your freedom. I'm only telling 1 day in a month to post them. No, it can be batches. You can divide them in batches. See, that is what we are telling. You have the freedom. You do how you want. You can implement it as well. You see your logistics, your situation, but ensure that they get exposed to it. Because peripheral, they will see the different cases. What they see in your opinion is different peripheral opinion. come to that. Totally, if you see, we have 60 hours. 60 hours is not sufficient for us. Okay. Now I have put these visits only for these which are must. Rest of the time you use it for your field visit. You borrow from somebody else for field visit. And there is no other option.
Somebody else, they have same problem.
So if you see, we have so many field visits.
Sir, unless and until if it is not there in this,
No, sir. Now if you see here, we have mentioned the field visits, right? We have already mentioned that you have to do. But we have not mentioned this is for 5 hours, 2 hours. For some, they just go for 3 hours. Some they go because they know it is distance far. So we cannot do that. So we see now, for example, listen, we are told they have to do health camps. How many health camps minimum they should participate in 2 health camps in a month? So you might be doing multiple health camps. You may not post all the 100 students in one health camp. You rotate them. Each student should get at least some exposure. So you decide how you want. Huh? They will be, see, they will go into some clinical postings. When you,
whatever you want to tell us to do, that should be in the format of a table. So we can tell the college and do that.
no sir, that we cannot see.
Our own way, studies all the staff, all the other departments.
So that you can do as a calendar of events. See, that is not activity what we are planning. You can do calendar of events. So now if we give NCH gives you have to do as a table, then they will come and ask, did you do this, did you do this? Now you have the freedom, you can manage according to your timings. See, because those timings are different. Each university, they have different calendar of events. According to your calendar of events, you plan it.
at least give some hours, service hours.
That six-
What will happen when they are taking time table? It will not be underpaid.
No, no.
Students will not.
Sir, we have 60 hours of practical. So you plan according to that. Now suppose you say you identify to community need assessment. So what you will do, you can get down each area by 5 students. One day you can do the community based assessment. You want 1 day, you want 2 days. You give it accordingly. If I fix you do community based assessment for let's say 2 hours, I already have developed that. It is ready, but that cannot be uniform for the entire country.
So we used to go 2 hours every week. So can we do now?
You can do now also if you do, suppose if I take 9 months, if I do 2 hours a week, so we are getting how much? 9 into 72 hours we are getting. We are having what minimum 60 hours. So 72 hours we are getting, so adjust all of that. And then some Sundays, some holidays, you can post them somewhere, so all that will be managed, can be covered. So almost we need 100 to all the visits and all 100 visits. We try to put it. We have worked out that number of hours. We did not put because that becomes binding on each of the parts. Now, if अगर आपको चाहिए तो मिलेगा, लेकिन you will not have the freedom. That is what you will not have the freedom to do that. You are already doing, sir. We have just put it in the document. Nothing is extra over here. We have only 1,200 hours. In that, everything is managed. So this is the competency table for practicals. May I have your attention, please? So competency table for practicals. If you see practical lab work, we will see whatever it is. So here it is P. Same you can see here. It is P 1.1. So content, outcome, entry behavior is they should know what is the theory of that. And then what are the specific learning objectives, and then the activity what they're supposed to do, and how you're going to assess those. Okay, this is for practical problem. Now we come to assessment. I will not go into these details because you already know. So we have two types of assessment: formative assessment and summative assessment. Formative is only for feedback. We are not telling their parts of it. Okay. Summative is for exam.
So nowadays we are asking assessment, we are asking if the student is a slow learner, what kind of actions you have taken and what kind of improvement have you made?
You can use, we have used all these kind of assessment. For slow learners, you have workbook, practical, reflective writing, assignments. All these are for formative assessment. Okay, this is university theory math, so summative assessment.
Sir, for practical assessment, the college is charging much for the students.
What?
For the paper sheet, college is charging much.
You mean to say charging?
Charging others,
That I cannot tell anything. No comments. That is it is left to individual college and rules and regulations.
Everything is going according to PCI, everything is regularizing, but what about
You didn't hear our chairman speaking? Dr. Quran, he already told, they have already given him how much payment has to be, what which will be done scale. That's every arrangement in college.
हमने डिक्लेयर किया मंजूर कराना तुम्हारा काम है।
हाँ वही
ऐसा नहीं है जैसा आपके बैग कंपल्सरी कर रहे हो तो वो भी कंपल्सरी होना चाहिए।
सब कुछ रिकॉर्ड हो रहा है।
बोले तब तक चिंता नहीं सर।
implementation will become
Sir, I'm not in
this implementation will become
next year. Now the students will come to second year, one day after year.
of salary.
We will
Next year.
So what I can do, please tell me what I cannot do.
We were expecting simple answer from you.
I am also in a private college to be. Okay, now we'll see how the teaching learning methods. I will not go into details, which already we have done. So we have three types based on the size of the classroom: domain learning and teacher or a student control. So basically, like large group, small group. This not only explain. So you have based on the size of the classroom, you can select the teaching learning methods. Then domain, which domain, psychomotor domain, cognitive domain, affective domain, or based on student control or teacher control, or the context, whether it is theory or a practical according to the theory. Okay. So now this is just giving you an overview of what. So now suppose based on the large size, if the size is large, big, so you can use lecture, symposium, teaching or panel discussion. If the group size is small, demonstration or tutorials. Okay. If it is like here, the learner has more autonomy, here learner has less autonomy. This is one way, here it is two way. The learner is involving in. So these are the methods based on the size. Journal club. Journal club is basically you have an article, student or anybody that takes this take up an article, research paper or an article. They will go through that and then they will discuss they will see each of them whether the objective was good, whether the methodology was correct, what could have done better, what is not done better, they can involve. And they can also learn the theory part of the law.
Like for example, board study, this is given, and group of students are there, and then they will come and they will present.
They will present. So you will have the teacher will be there to support them. So that's a journey. So you can use any of these things. So now based on the size of the classroom, these are the large group lecture, symposium, teaching that we saw. Okay, now these are all the different methods. So you can have, if it is in between, like demonstration, field based brainstorming, assignment and projects. Now these are where the teacher is having the control. Okay, and here it is, it could be lecture, symposium, teaching, demonstration, brainstorming, both can be done. Brainstorming is you keep a topic and then they discuss among them later. It's like free mind to talk. Their viewpoints are taken and then like for example, you have you start some, you give thought processing question and they will discuss among them.
You call it bus class also.
Bus is like you have a break. Among them you tell them to discuss and then come out. That's all. Buzz is different than the brainstorm. Buzz is like between small number, brainstorming can happen in the larger amounts. So now based on the student control, you can have seminar, role play, conference, workshop, group discussion, self-learning resources. These are all methods you can use and students can. Now based on domain, cognitive domain, psychomotor domain and affective domain. So for level 1, recall, then level 2, level 3, it's like this, you can use any of those. Psychomotor domain, okay, I'll come to that, so these are all different levels. Now based on cognitive domain, these are the methods what you can use. Psychomotor domain, demonstration, project work, individual practice, workshop. Then affective domain, you can have group discussion, panel discussion, role play, case study, problem-based learning, all these methods. See, there are difference between a method and a media. Method is what you do, media is the medium what you are using. Okay? So, these are all the different large group methods which you can use. These are all mentioned in the curriculum, and these are all non-lectures and practical. Now we will quickly look at what are the media, teaching learning media. This you must have heard from Pune Public Attention Span. So that is 20 minutes, so that's why you do some activity based or something. So if you see TED Talks are also only 18 minutes. So now this is what Sir spoke about. This is based on the Varian's observation about what impacts. Okay, 55% is the body language, 38% is the expression, and 7% is the words what we are using. Okay, the voice tone, what it is, only 7%. So this also was explained, so I will not go into this. So these are all active work. What students are involved, visual, demo, then writing, workshop, hands-on, and the real life experience is what retains them more, 90%. So the same thing is put here. So what it says is 10% is what they read. Okay, what they can retain. 20% is what they hear. 30% is what they see and watch. 50% is both see and hear. Okay, 70% if they do something, 90% is real life. That's what is the retaining capacity. So as far as possible, give them real life experience, do hands-on work or something like that. The problem is, lecture they can retain only 5%. Anybody can retain 5%, but 90%, 95% we are dependent on lecture. Only 5% they are retaining. So make it upside down, do hands-on work, give them more work, real life experience. Actually, in community medicine we can give a lot of real life experience. So why we have to use media? To signal what is important, to reinforce what you are saying, to engage all the senses, facilitate different learning in students, like everybody learns differently, so that everybody for auditory, visual and kinesthetic learner. And so how you can prioritize? First priority should be real life situation. Next is continuous situation where you are giving a simulated experience. Okay, you are creating an artificial real life experience, then something motion, and then still pictures. So this would be the best way what to do. So how do we select the medium? How do we select the medium? What type of group, depending on the domain, depending on what SLO you can select. Okay. Domain. So based on the learning objective, based on the learners, what kind of learners you have, okay, and what you are going to teach, what the way you teach. Okay. So this already is discussed, projected and non-projected. Okay. So these are all the projected media, non-projected media models and all. Flipped classroom is like generally what we do is in the class they are teaching, then they go back, they do something. Now they learn there, then they come here, we flip it, and we do some activities. That is they do, yeah. Students love this more. So here you become, student is passive in the classroom, but you tell them to read and come, you're flipping the classroom. They read and come, and then you do all the activities. That is what is in the classroom. So now what we are going to do is the activity. What is the activity? We have told learning cycles are spoke in the morning. So based on that, now what is learner activity? Because our focus is more on the learner activity. So learner activity is basically about the type of activity that the learner will do. Need to engage in the active and learning it to learn that outcomes. Okay, what they are supposed to do to integrate learning outcomes. So this will provide experience that will enable the student to engage in practice, gain feedback, and on the specific outcomes. Now there are different types of activities you already been doing. Most of the time, what activity you tell them to do? It's basically they are what they are doing is you tell them they are learning from you. That's the way activity what it is, right? So now that is called as acquisition. So Diana has told there are 6 types of learner activities. One is where the student is acquiring knowledge. That is, they are acquiring knowledge from the teachers. Could be by lectures or whatever activity. Next is inquiry. They do inquiry by themselves. What is it? You know how they compare, they critique, they do. The next one is what they do is they discussion. They discuss among themselves. They can discuss among themselves. They can discuss among you or somebody outside. Anybody they can discuss and they can learn. Okay, or they practice. Okay, they take, you give some task for them to do and they will do, that is practice. Okay, and then there is based on collaboration. They work together with their fellow mates in collaboration. Finally, they do something, production. So these are the 6 ways that student can learn. By acquiring, acquisition, inquiry, discussion, practice, collaboration and production. Now, for community medicine, we can use all these learning activities. Correct? Each of the topic you decide what they are supposed to do. Now you can tell them to collaborate and do something, group activity. You can tell them to prepare something like, they can write some stories, they can write poems for the community, or they can do some models, they can do education, they can do act, pamphlets, anything they can. So you create creativity you can bring out from it. Use all the methods. Learner activity. Okay, so this is one example I am giving here. Now, learner activity, this is like how to decide what activity can be done. So you ask these 5 questions to yourself. When you ask to yourself, then you will get what activity can be done. For example, what would motivate the students? What, because the cohort, some cohort would want to go and do something in the community, something they want to do in the class. So depending on that, you can do what will motivate them. According to that, you can decide what they want to hear, what they want to see, what they want, and how you can engage the topic. Okay? Whether it is possible for you to give real life example, use that, or do some demonstrate, show them something to practice. So like this, if you ask some questions to yourself, you can create an activity for students. Okay? So we are not telling for this topic do this activity. It is left to you. You create whatever activity. Okay. So some of the activities here are listed as an example. Okay, it can be assignment, group, individual, self-directed learning, preparing charts, case study, reflective writing, self-explanation, community-based activity. So this is what we do, some activities in our college. So this is like, because it's a dengue season, they go and then they do the larval survey and all that. Other faculty, junior faculty. Okay. So this is like, for school health, nutrition you can have, something, school health program. So if you see like, if you have a plan, for example in nutrition, we have planned a suitable nutritious diet for a woman during pregnancy and lactation. Now you take them to a PHC, there must be a ANC day. So you can tell them to, for this particular patient, plan a diet. Or in your OPD, if a pregnant woman is coming for ANC, you can tell them, plan a diet or something. That's how you have to give a practice. And it may not be possible for everybody to do. You can give a hypothetical situation, you can create a mystery client or somebody that assume that this is a pregnant woman of 9 months or 3 months old or something, right? Trimester, then they can create. So that again you can do formative assessment or you can do theoretical. So this is self-directed learning. Self-directed learning is somewhere the individual, they take the initiative either with help or without help. So you may help them. So what they know what they are supposed to learn, learning objectives, they have the goals, which is already assembled as well. So you can give some topics as self-directed learning, which are simple, where there are no concepts. So don't think that we should do everything in the class. So not necessarily everything has to be done in the class. Some can be given as self-directed learning. Only do those topics which have more concept based where you have to explain it. Others they can do. So for that, you build an environment, learning environment, okay? You motivate them, you provide some facilitator in initiating that, and then be available whenever they need. So this is what is called as scaffolding, okay? So now the scaffolding are two types. One is semantic scaffolding, another one is adaptive scaffolding. Semantic scaffolding is where you give the learner all the instructions before it's okay. You present in advance all the objectives before they start anything. Adaptive is, it is like as they learn, you give them advice and what needs to be done. That is what is adaptive. Okay. So this is again depending on the cohort, depending on each individual students you have to handle. So this is basically for practical, which is called Patton's 4-step approach. With any practical work, you start with a demonstration. You demonstrate, then you do something called as deconstruction, where initially you are demonstrating some work. Okay, this is basically for practical, not for every topic. So once you do the demonstration, the next step is, while you doing demonstration, you explain to them. Then you tell the student to repeat it. Okay. Then you tell the student to perform. So now the learning is much better. Okay. So this is called Patton's 4-step approach. So now integration. Any questions till now? Quickly finish another few minutes.
Sir, one question is there.
Yeah.
We are teaching that computer medicine is such a depth, and we are giving that insight, we are developing insight and students. But in a state like Maharashtra, where people are not getting a job, when they are learning all these things, they are not getting it. So the students, when they are taking admission, if they are doing that, they are going to get some, they will become CHO, community health officer or something in public health. So that is how we can attract the students. But at the end of learning all this, they are not getting this job. Some of them are getting jobs in the NGO and WHO, UNICEF, but not in government.
Sir, if you see, it depends on what level where they are. So nowadays, not that every doctor is getting a job. So they do qualify higher, they do their masters like MD community medicine or MPH or hospital administration, they won't take up such kind of. Only few posts are bachelor's students. But as a doctor, as an individual, he should be able to manage. Why are you only looking at only government jobs? There are a lot of other jobs which are available in NGOs, in corporates. They can do everything in their own village or in their own community. So we cannot create jobs. We can only equip them with all that. That is why what is our role? So what is our role is make them competent enough to manage any kind of situation. So we will do our job best. If we do, yeah, make them warriors. They will go and find and get whatever they want. Okay, now integration we have already done, so I am not going to do. We were supposed to do some activities and skipping all these things. So now this is for lesson planning, like how to do. This is not that we have to do, this is just for us to know how we can do better. Before going to the class, identify the objectives, plan what you are going to do, and create the realistic timeline, and then go to the class. During the class, share the lesson plan, what you are going to do with them, what are the teaching learning methods, tell them before only I am going to do this. So if they come prepared, you don't have to do everything, you just explain what it is and then you can move. Okay? Then after the class, reflect what was good, whether I should have done this much better, can I use different methodology, so we do this cycle.
So is there any format for lesson plan?
Lesson planning format is there, but only here we removed it because most of them didn't want it, because that is, yeah, it is supposed to do, it is left to you how you want to do. So NCF is not insisting, but NAC is insisting. Yeah, NCF is not insisting. So if you want, as per you want, I can show you the format. There is a format is there. That is, it is left to each college, but we have a basic format. If you want, I can show you later.
So we have to do it for every lecture.
But we are not insisting. Your NAC will insist. Huh? अभी चार Okay, now assessment will finish quickly. What is it? We have to do assessment, practical, and then viva. So formative and summative, you have all these things. So we have two assessment basically. Two PAPA 1. Okay, that is periodic assessment 1 and periodic assessment 2. So 1 in 4th month and 1 in 9th month, and term test is at 6 months. So if you see that syllabus, what we have, 6 months syllabus. So it should have covered that. Okay. For PA, term 1 should have covered that term 1 full term should have covered. Okay. So this is for the practical marks distribution. Theory we have got 100 for both the years. Practical again 100. So 50 marks for practical, 40 for viva, and 10 for your written analysis. Okay. Yeah. So this is how the 100 marks theory is distributed.
So the general marks are also very important.
It's coming. That will come in the practical. So this is for the 100 marks theory paper. You have 5 long answer, 8 short answer, and 10 multiple. So now here is where our blueprinting is coming. Where for each of the theme, the topic, what should be asked. So this is the marks. If you see there, we have 6 marks. So either it could be you will have 5 marks and 1 MCQ. So similarly, here you have 10 marks. You can have 1 long answer, or you can have essay, 2 essays. But here we have given, there we have already specified what it is. Fixed. I will show you a question paper blueprint also. Okay, this is for 3rd year. Okay. So now see this example. This is a question paper blueprint. This is the same thing what we have already taken. But only thing is we have question number 1 to 5, they're all 10 marks question. So see the theme, it is coming from theme A, nutrition of the human. Then F is environment. So now question number 1 will come from nutrition only, 10 marks. Question number 2 will be from environment alone. Okay, so like that everything is specified, blueprinting has been done.
There is no option.
Huh? No option.
All are compulsory.
Clear? So now if you see the engineering health, we have to make 2 marks, so you can only 1. Okay, occupational health, how much we had? Nutrition we had like 16 marks, right? So we have 1 10 marks, 1 5 marks, okay, and then 1 mark. That's how we got. This was the most toughest job because we had practiced to the questions. Distribution was not easy. That is, this is 3rd year. So that will come in 4th year. So this is from 4th year. So this is the 4th year. So now coming to practical. So what is that? We have 50 marks practical, right? We saw 50 marks practical. So now this again we are using OSPI. Okay. So now what happens is in OSPI everything is structured. So the first clinical social case taking is done, which is of 10 marks. 1 question will be there. Spotters 5, which will have around 5 spotters, 2 marks each. Experiment 1 experiment, 10 marks. Counseling 1 counseling, 10 marks. Sorry, 5 marks, 1 exercise. Like you have biostatistics or epidemiology or whatever nutrition exercise. Record 10 marks. 10 marks. Okay? So your 50 marks are there here. So now if you follow this in 2 hours, if we do OSPI, we will finish the entire practicals in 2 hours. Okay? This calculation is done based on an average of 20 students in the batch. Most of the universities on an average in one batch they have 20 or 25 students. Some students, some universities they take 35. So you can plan accordingly. Okay. So this is taken on an average of 20 students. So if you have 20 students, so the OSPI stations will be like this. So you have 30 minutes, they will go for 1 case study. This case study can be in the community or it can be in your in your IPD, or you can get a patient from the community. Okay. Then you have a spotter station, 5 spotter station. Let me finish. 5 spotter stations, so you have 5 students writing, 2 marks, 2 minutes each, and 1 minute for them to move. Suppose you have 5 students. After 1 minute, he has to move to the next one. So don't make them write the entire essay there. 1 minute identify and 1 or 2 points. They have only 1 minute time. Okay. So they just move on and 15 minutes total is complete. 2 minutes plus 5 minutes for more. So 15 minutes is done. Next, these 5 students will come for experiment. Experiment is 15 minutes, 1 experiment. So these all 5 students will go to counseling. Like you have, water purification, whatever. Apparatus you have that boiling water. There are so many items. Adulteration is there. Then ORS preparations. Some they are listed. You can give them. It's already there. It's already there. Okay. So now those are experiments. Then 1 counseling. Like it could be for nutrition, alcoholism, anything, because communication skill is most important. It could be anything, so you can give any counseling. Okay, then you have 1 problem. So if you see this, 2 hours, practical is over, then you can use for Viva. Now, problem is like your biostatistics do some mean
important is with the practical stations. Normally, the person should have communication skills.
Yes.
Now, earlier, the teacher cannot go for even 5 students, how they are doing this. How do you notice?
See, now for example, you have these all stations, you don't need anybody to be there. They will be rotating and going. Okay, you have 2 examiners. Okay, 2 examiners are there. You have 5 students doing at a time counseling. 5 minutes you are telling them 10 minutes. So 2 if you do in 15 minutes you finish it. That is what during white on. Or you can have some observers. You can have some observers with you. Who will observe whether they are doing.
4, 5 observers and they are standing in front.
Yeah, you can. It can be done. Sir, you are very smart. You know what to do. That is correct answer. So, structured Viva is again 2 examples, one internal and one external. Then they will have to come with Viva cards. So everybody will be prepared. So we have structured the Viva, how many questions for each student. Internal how many questions, external how many questions. Okay? So all students will have equal number of questions. See, generally what we do is, we come in the morning, for the first students we take half an hour, 45 minutes. As we go on reducing the last 5 students, but that cannot be done. Because every student should get equal opportunity, equal question, and difficulty level should be uniform. So that's why they are doing the structured Viva and Viva cards. One day you finish. Depending on number of students, this is for 25 students for a batch. I am telling what is for a batch. Okay, so you have totally, you can have 2 lower order, so it's not middle order. You don't ask lower order questions, equal level. You should ask either interpretation or problem solving. OSPE, because OSPE is for clinical examination.
So you can have combination of this.
We have one for clinical.
Like hypertension, we are having everything.
You can use it.
Yes.
So we can do
You can do both. Sir, both. You can do both OSPE and OSCE you can do. Docs we cannot do here unless you are doing some procedure. Docs is for procedure, you are not doing. Okay.
So no, so DOAT assistance performance.
That is okay. That is again. Ma'am, you use whatever you want. It's only that we want you to do it in a uniform way. That's all it's structured. So the freedom is given. Okay. And see, we have given the list of all the types of assessment. You choose what assessment would be good for that particular question. Not that, see, some can be assessed by observing. Some can be assessed by when they are asking questions. So you assess accordingly. So this is what is the Viva. This is for 3rd year. So you have the theme B, A, P, B, B, C practical. Okay. So sorry, this should be. So here you have C1, 1 question, C2, 1 question. That level, interpretation level. Okay, in this theme you will ask question for community health. Here behavior health, education. So like this, thematic, everything is given. Okay. So every student will get the same kind of questions, same kind of same topics, but the questions will be different. No bias. Same topics, question will be different. So you have multiple Viva cards. As the student come, you can choose. So you will have written there. So either you prepare for an external also, or you tell the external to prepare it. So you have yours. Step 3. So this is how the Viva cards you have prepared. So assessment we have theory, practical, and Viva. Okay. So now how we have prioritized. So we have prioritized everything according to must know, desire to know, nice to know. Must know is essential for them. Nice to know is important but not critical. Nice to know is beneficial but not necessary. Okay. So this is how the entire syllabus is prioritized. Okay. So now why this is in assessment is 70% of ours is must know, 20% is desire to know, 10% is nice to know. But when it comes to assessment, 80% is coming from must know, 20% from desired result, and there is no question from high school. Okay. Similarly, in your Viva also, have only must know questions most of them. No nice to know questions. Now, how did we come to this? How did we decide must know, desired to know? It's based on frequency, that is frequency and impact. How often, frequency is how often a disease is occurring. How often the student will see that particular case or condition. Okay, you come across that becomes a frequency. And the impact, what impact it is causing, whether it is mortality and morbidity which is high. Sometimes it may be high impact, the frequency will be low. Okay, so according to that, the importance of it. Okay, so that's how they have decided as must know, nice to know. So now, this we already seen. Questions, you have 5 questions of 10 marks, 8 questions of 5 marks, and 10 questions of 1 mark. Okay. So different types of questions you can have. This I'm not explaining; it's already done. Just an example of modified essay questions. So you have one situation, and you can ask different questions according to that. But when you give, you tell first question how many marks, give the weightage for that. So I say you an example and I say you an example. Okay. What do you see common in each of these questions? Statement. They are all active. We are not asking what, when, how, we are asking what they are supposed to do because it's a competency. That's why all questions will start from 90. Okay? So just to see an example, we said initially your SLO will get converted into question. So you have an SLO here. Describe the various technologies and standards for treatment of hospital-based or biomedical waste. So that is getting converted into discuss the installation as a method of biomedical waste. Okay? Your objective SLO is getting converted into question. Every question must start with an action. So we are not doing the activity, we are supposed to prepare a question. So this I am not going into details, that is for the practicals which we already saw. And Miller's pyramid we already know, so I am not going into that. So this we know. This is for a checklist because when you are observing something, so how a checklist? Now suppose you have a question of, you are telling the student, demonstrate the mother how to prepare rice. Okay, so now this question you have asked them to do. So learning, they should be able to demonstrate to the mother. That means he is explaining to the mother how to demonstrate how to prepare ORS solution. So for that, the checklist. So these are the checklists. Yes, no, sir was telling yes or no, right? So you have that 10 questions. Whether he is meeting the patient, he is showing up the packet, how to see the expiry date and all those things, something like that. So you have, and then whether he has done all these things, you can do. So similarly, for whatever activity you are telling, prepare a checklist. What they are supposed to do. So the question is there. You don't have to be there. The observer can see whether they have done this, done this. That's all. Okay, now I will stop talking. Then you can see this. Now we are coming to the last aspect of the Viva. So what is Viva and all? I'm not going to talk about it. This is the exam Viva situation, right? Most of the time we ask only what the student doesn't know. So you have the telepathy, you know what he doesn't know, you ask only the same questions. So student mindset is like that. Finally you tell, you know something. So now we will not give any of these. So we will not start laughing at ourselves. So we will go to the structured Viva. Okay. So this we already know how the structured Viva should be there. I don't need to talk about that. So Viva questions you ask test the depth of the knowledge. Okay, ask about the theoretical and practical questions you can ask. Mostly professionalism, you can check for aptitude, professionalism, analytical skills, alertness, communication, honesty, ability. Sir also explained why what you
सर मगर आपको कार्ड देने वाला
आपको बनाने हैं, हम नहीं। अरे सब कुछ अगर एनसीएफ दे देगा तो आप क्या करेंगे? आपको फ्रीडम नहीं, अगर कार्ड देंगे तो लीक हो जाएगा, फिर लीक के जैसे हो जाएगा फिर प्रॉब्लम। Okay, now this is all about Viva. I'm not going to go into details. So this is structured traditional Viva. So now how you have to do your Viva is prepare questions. Difficulty level should be uniform for all the students. Based on that, prepare a Viva cards. Tell the student to select and rate their accordingly. So this is how Viva cards can be. You can have your Viva cards. So this is a survey what they have done in research and traditional versus structured Viva. So everybody said structured Viva is better than student Viva. So what you can ask factual questions, something which is probing their thinking capacity, challenge them, okay, and then something which can be hypothetical also. The last student will be like this after the Viva. Okay, so we have our objective. We said these were our objectives initially. I hope we are able to fulfill all the objectives. Any questions?